How's everyone doing? Yeah? I think you guys are as excited as I am about this. So let's get right into it. So it's my great pleasure to introduce two close friends for this fireside chat, Dr. Chelsea Clinton and Dr. Megan Ranney. Dr. Megan Ranney is a dean at the Yale School of Public Health. I am really pleased to call her a colleague and friend, as I am also with Chelsea, who is the vice chair of the Clinton Foundation. This theme today for the fireside chat is championing health equity through innovation. I think you both are very well aware of their bios, so I'll spare you that, and I would love for them to just jump right in. So really excited to have you here today.
Thanks, KP. It's a joy to be here sitting with an amazing woman on a day when we've just had our first woman president of Yale in our history. So a truly momentous day for this institution, and a joy to be with you as such a champion of women's health and women's rights on this day of all days.
Well, Megan, thank you so much to you and to KP. I also want to thank everyone here at Yale Ventures and at the Yale School of Management for welcoming us so warmly. I want to thank everyone who ensures that we're well hydrated, because unfortunately my allergies have followed me from New York City. And it just is always a joy to be at Yale. I have really wonderful memories, as I was sharing earlier with Megan, of coming to my parents' Yale Law School reunions. I didn't quite understand why we had to come every few years, but really driving by the Peabody Museum just brought back such kind of joyful moments for me from many decades ago. And it is a joy to be now here on this stage with my friend and your terrific head of the School of Public Health here.
Thank you, Chelsea. Well, I wanted to start us off by talking a little bit about your work, and then I'll transition into the larger kind of sphere that many of us here are in. I know that we've been connected as both innovators, parents, public health practitioners, but also as folks committed to a better world. And to me, the scope of impact and the breadth of work that you're involved in is tremendously impressive, but also somewhat atypical. Many folks don't think of combining the various strains of work that you follow. So I would love for you to share with the audience, for those who aren't aware, what your current priorities and your various initiatives are that you're part of.
Sure. So I'll provide a bit of context by talking initially about kind of the origins of the Clinton Foundation through kind of what at the time was called the Clinton HIV/AIDS Initiative and now is called the Clinton Health Access Initiative, and then kind of reflect on how kind of that early work kind of set the ecosystem in which we work, but also kind of the zeitgeist with which we bring to all of the work where we're kind of lucky enough to do it here in the United States and across the world. And so, the origin of the Clinton Foundation really began when my father, to his credit, acknowledged that he hadn't done enough to tackle the AIDS crisis while he'd been in the White House. And he was thinking about kind of where to deploy his, if I may, like rather capacious brain and arguably even larger heart, and kind of the network that he'd built and his political credibility and his ability to kind of continue to gain and hold attention. And he decided to kind of direct all of that to the AIDS crisis, and specifically the inequity that existed, in the early 2000s, which is that most people, here in the United States who were living with HIV/AIDS were on antiretrovirals. Medicaid by that point had been covering antiretrovirals for a number of years. And yet, kind of looking outside the global north, the OECD countries, the wealthy world, kind of whatever your nomenclature of choice is, fewer than 10,000 people in the global south were on these life-saving medicines. The average price at the time for a name brand drug, whether you were here in the United States or not, was about $10,000 per person per year. And so my father, working with President Mandela, working with generic drug manufacturers, working with the nascent Global Fund to fight AIDS, tuberculosis, and malaria, working with kind of large, kind of newer philanthropic funders like the Bill and Melinda Gates Foundation, kind of structured a public-private partnership to work on both the demand and the supply side. So the supply side to kind of lower the cost of kind of inputs into kind of generic drugs, and the demand side to kind of guarantee huge bulk price purchases. That shifted the market from a high price, low volume one to a high volume, low price one. And fast forward today, the average cost per person per year for a full course of antiretrovirals is a little less than $60 per person per year. Of the about 30 million people across the global south who access antiretroviral medicines, about 27 million of them access them through agreements that we negotiated. Now here in 2024, the CHI team has negotiated about 150 market-shaping agreements, most recently as relates to hepatitis C. Hepatitis B and hepatitis C collectively affect about 320 million people every year. For those of you that are not kind of public health wonks, hepatitis B is vaccine preventable. Hepatitis C is largely curable with early detection and treatment. And yet, similar to the AIDS crisis, the vast majority of people who aren't lucky enough to be born in places like Yale Hospital or to live in places like New Haven may not have been vaccinated at birth or may not receive early detection and treatment if they do get sick with hepatitis C. And so similar to kind of the work that first catalyzed the Clinton Foundation's market-shaping dynamism, we've worked with a wide variety of partners to lower the cost of hepatitis C treatment from about $2,600 per person to, again, less than $60. And we're now trying to hopefully kind of marshal similar levels of resources from philanthropic funders, from bilateral funders like the United States, to hopefully ensure that anyone anywhere is able to access both the vaccines that any of us should be able to do, but also kind of the treatments that we may need. The last thing I'll mention is out of the realm of kind of what we often think of or conceptualize public health as, but of course still has huge impacts on public health, and that's early childhood education and well-being. About 10 years ago, my mom and I started something called Too Small to Fail. It's a little tongue-in-cheek. Our kids should be too small to fail. To try to equip every parent or grandparent with the resources that any of us would need and all of us deserve to be able to read, sing, and talk to our children. That's important, partly because it really builds such extraordinary and profound bonds between kind of caregivers and the small humans in our lives. It's also important because we know that 80% of our brains are built by the time we're 3. And so establishing that architecture is what hopefully then enables a child to grow up and decide to go to Yale or to culinary school or to the US Air Force Academy or wherever their dreams may take them. And yet we know that about 60% of children are showing up not ready for kindergarten here in the United States. They don't have the kind of pre-literacy and pre-numeracy skills that generally kind of should be expected for kind of kindergarten, so that they're able to learn kind of everything that we would hope that any of our children would absorb and know and kind of further fuel their curiosity in their first kind of formal schooling environments. And so we've worked again kind of on the market shaping side to do things that might seem somewhat unexpected, like we've worked with the playground industry to kind of lower the costs of literacy-rich playgrounds so that WIC centers or preschools or public parks are able to now have playgrounds. And we have about 1,200 of them, including some right here in Connecticut, that have prompts on them to encourage parents or grandparents to ask their kids, how many colors do you see on the playground? How many times can you swing back and forth? How many steps are there on the ladder? Things that might seem individually small, but aggregate together to be quite potent in helping to kind of fuel a child's brain development. And then continuing to work with maybe some unlikely partners like the Coin Laundromat Association, because low-income families spend about 2 to 4 hours a week in-coin laundromats. And so we now have built more than 600 libraries and laundromats, or adjacent to laundromats, sometimes working thankfully with shipping container companies who've been willing to donate their shipping containers, which we then can repurpose into libraries. So very much trying to do whatever we can with whomever we can.
I love those examples of the ways in which you've built cross-sectoral collaboration to scale the science that we know improves health for populations. And I know we were talking about this a little before about kind of one of our challenges, and I think for many of those in the audience, I know you guys are here because you're interested in art ventures or climate, or hopefully many of you interested in health ventures. One of the challenges is when we think about kind of that social entrepreneurship or social good side, we often get stuck in one model of thinking about creating the science and then disseminating it out into the world, which is philanthropy and only people who kind of have been trained in public health or in medicine or maybe in environment. As you're describing those various streams of work, whether around HIV or hepatitis or early childhood development, I'm struck by the ways in which you've brought different groups together and are making sure from the get-go that it gets out beyond its beginnings in philanthropy. I'd love for you to comment a little about that and the way that you're thinking about kind of innovation in this space.
So one of the things that we try to do is certainly always not be the only people around the table. To have diverse stakeholders around the table, to always have people who are actually kind of living in a challenge in the room at the table. We don't think that kind of empathy or lived experience should be bolted on later. Kind of it should be kind of designed in, really kind of led by, kind of from the beginning. And we work very hard to have clarity around like what gets rendered unto whom, like what needs to come first, kind of how do we have real shared accountability kind of as we hopefully are moving toward a goal, and how do we also kind of continually be in a posture of learning. And so we found, for example, even just on the playground example, that we had to adapt the playgrounds to places that are very hot. Well, that may sound obvious, but it wasn't initially obvious. We're like, oh, we have like all these great like learning prompts. These are going to ensure that playtime is still like talk time and teachable time. But actually, it also needs to be shaded kind of for places like Phoenix, because otherwise the playgrounds are only really effectively usable maybe 7 or 8 months out of the year. And so I think, Megan, it is having kind of the sense and sensibility, kind of the confidence around, all right, we now know a lot about a lot, and the humility of like, and we still don't know a lot about even more. But how to have kind of the right stakeholders around the table who have a shared kind of ethos and commitment of building kind of for scale and sustainability, right? Not just sort of something that might have an impact in a community today, but hopefully has a multi-generational impact in a community. And being able to acknowledge when maybe we didn't get it right the first time, but that got us closer to then being able to get it right the second time. Like some of our playgrounds now have to be shaded.
And more will need to be shaded as the years pass based on what we're seeing for forecasts for the years ahead. Can you talk a little more about kind of this for-profit versus nonprofit approach to health innovation and improving the health of communities? I know that you both run Metrodora Ventures, then obviously are involved with the Clinton Foundation as well as other nonprofits. Do you mind sharing a little bit about your thoughts about when and where these various avenues might be appropriate?
Sure, I'll start with the Clinton Foundation, and then I'm happy to talk about Metrodora. So at the Clinton Foundation, like we are not a generic drug company. We're not a generic device company. We're also not the public sector, nor are we kind of multi kind of stakeholder, large institutions like the Global Fund. But we now know a lot about how to optimize around cost for inputs. And we know a lot about how to optimize for scale. And we know a lot about how to ensure that that scale optimization can be sustained kind of through ensuring that what kind of global South governments can pay for is kind of at its kind of highest, like what we call like maximum efficiency. kind of for what their own priorities are, whether that is around hepatitis or tuberculosis or maternal and child health or cancer. We're increasingly doing a lot of work trying to bring innovations in particularly pediatric cancer that is a growing priority for many of our partner governments in the global south, and trying to figure out how to bring those kind of treatments and therapies into their health systems. And so I think we're just very clear about kind of what we can provide, what often in kind of global public health is called like technical assistance, or ongoing monitoring, kind of risk assessment, adaptation, and what we can't. And we also, do a tremendous amount of work to ensure that the agreements work not only for kind of patients, providers, and governments, but also for our kind of drug and device partners. Because if kind of the agreement in hepatitis doesn't work for the generic manufacturers today, they're not going to have an interest in working with us kind of on the next priority tomorrow. And so it has to work for everyone in the ecosystem. And patient-centric for us does not mean patient only. Because if we're only trying to solve for a person here today, kind of to us that feels quite contra to kind of public health and population level health. Kind of Metrodora, my very early stage investment fund with a friend looking to support founders who were building from a place of lived experience and deep empathy in health and learning, really emerged, admittedly, partly because I kept meeting women who were having a really hard time getting funding for their women's health enterprises. And they would often talk about how their male colleagues seemed to be having an easier time. And while this was, of course, anecdotal, it was finally like pretty enraging to me. And I am a person who generally, when I see a problem, either think, well, what can I do to solve it? Or how can I try to help support someone else in solving it? And how do I ensure that, again, that hopefully solution isn't just point in time? And so we started with this simple premise that we should be investing in people who are trying to solve the challenges that they themselves, their families, or their communities have experienced. That has then led to some really kind of also quite funny moments when I was helping a company that we had invested in very early that is midwife-centered prenatal and delivery and postnatal care. So OB/GYN supported, but midwife-centered care. When I was helping them raise their next round of funding, I was talking to, admittedly, a man, but none of the men in the audience would say this. Like, wow, like, how did you find this innovation of midwifery? And I was so like gobsmacked that what I said, and this was maybe like not the most professional response, as I said, I know that prostitution or sex work is often thought of as the oldest profession, but with all due respect, like midwifery is the oldest profession. Like, where do you think any of us came from? But experiences like that have felt really just continually like this should be part of kind of the portfolio of what I'm lucky enough to do to try to protect and promote public health and protect and promote and amplify kind of anyone and everyone who wants to really center and support, especially women and girls.
So that's a great pivot into women's health, which I know is an issue that both of us are quite passionate about. An earlier panel highlighted that only 1.8% of venture funding goes to women founders. And yet,
the number of people who sent me Melinda French Gates's op-ed yesterday were like, did you know this? And I'm like, I did actually know.
Actually,
less than 2% of venture funding goes to women's health. And I also know, which she didn't talk about in the article, that less than 15% of federal government funding in health goes to women's health. If we look across the NIH, kind of the CDC, ARPA-H, the DOD, kind of all the different parts of the federal government, many of which we don't often think about as having kind of a major impact on health research, but the DOD actually is a major kind of funder of health research. And many of us actually are beneficiaries of their research over generations in a myriad of ways. Less than 15% goes to women's health.
And it wasn't until your father's presidency that please talk about the 1993.
I love the 1993 NIH Revitalization Act. all of you are like, wow.
All of us science dorks are like, this is a really big deal.
It's a really big deal. And though also, while I'm incredibly proud that my father signed this legislation, credit where credit is due. In the 1980s, led by the Women's HIV Law Project and others, there were a series of lawsuits filed against the FDA for the failure to include women in clinical trials. This was having quite devastating effects in the first line of antiretroviral medicines, which were behaving quite differently in women with HIV than had been shown and were continuing to be observed in men with HIV. The FDA lost a number of these cases, and kind of that prompted the NIH to recognize that it needed to formalize kind of requirements of kind of federal NIH funding into areas where kind of the US government was making an investment, saying like this is like a public priority effectively for the United States, that women would have to be included in those trials, and ultimately also the FDA revised its own guidelines. That though should be sobering to all of us who are women here, because it does mean that we take things probably like Tylenol, that sure, like billions of doses have, maybe even like tens of billions, hundreds of billions of doses have been taken by women over time. So you'd hope there'd be safety signal, but we take things all the time that were not tested on us. Maybe more alarmingly, it wasn't until my mom was in the Senate working with some of her new Senate colleagues just over 20 years ago that children started to be required in pediatric trials. No, that also sounds slightly incongruous and maybe alarming to my fellow parents, because until then, kind of pediatric doses were effectively set at like, you're like 25% of a kid, of an adult, which for those of you who actually went to medical school or who have studied this, that's not remotely how child or adolescent biology works. So yes, incredibly proud of my dad, but also need to give credit to the advocates and the activists and the lawyers who held the FDA and then ultimately the NIH to account to ensure that women were included in clinical trials.
Staying on that theme, as we look forward to women's health, reproductive health, middle age and beyond, as us Gen Xers start to kind of cross over that boundary.
I was called a geriatric millennial. Someone asked me that in an interview. They're like, so as a geriatric millennial, I was like, I'm sorry. What?
The worst. So if you're pregnant over age 35, it's considered a geriatric pregnancy. I was horrified when I first learned this in med school.
There have to be some like marketing people and branding people in the room who can try to help on behalf of just all of us.
But these are ages that were not talked about. So we need to do a lot of research on kids and adolescents, but also middle age and beyond as we live longer and hopefully have longer health spans as well as lifespans. And meanwhile, hopefully continue to have some control over our bodies and our health. And so would love to hear where you think kind of the biggest innovations lie ahead, or the points that you're most excited to hear about people coming to you with ideas around in women's health.
Yeah, so I want to answer that, but I first want to answer the larger question around why we don't have more people coming with innovations in women's health, or in kind of middle age or kind of older women's health. Although here's another just fun anecdote, a little bit of gallows humor. Someone recently did send me a pitch deck for post-senior health. And I was like, I'm sorry. They're like, well, so like it basically was a funeral company. And I was like, I'm sorry. Like
I'm thinking seniors that have just graduated from college.
No. I was thinking like, like people over 100. Like I hear I should eat like 7 gin-soaked raisins a day. I don't know. No, that's not what they were talking about. So I do think it is partly, again, about the funding, about where we have availability of funding, whether it's through like dedicated like SBIR grants, like where the government is actually saying this is a priority for us, where we have venture or kind of private equity kind of funding available, where we have people kind of sitting atop certainly much larger vehicles and Matadora saying, you know, we are not only open to this, but we are excited about this as a real kind of market opportunity. I also, though, think it's about kind of what we teach. So,
why academia matters.
Why academia matters. So, not this institution, but I have a friend at another kind of prestigious medical school, not too far from this one, who told me that in their medical school, they spend 4 hours on menopause. And I see some of you nodding. If you're a medical student, does that then feel important to you? Does that then feel like, oh, this is an area that if I'm interested in will be valued by my professional colleagues? Is this an area where if I engage in like study or practice, I'm likely to get like an NIH grant or will help advance my career? Probably not. And so I do think, of course, Megan, it's about kind of, you know, what I as an individual or what any of us as individuals, the 400 or so of us who are in this room kind of may think are really kind of important and exciting and innovative. But it's also about kind of what our government policies are kind of saying are priorities, what academia is saying is a priority, what private pools of capital are kind of prioritizing. And so for me, like I will talk to anyone who's doing anything in kind of women or kids' health because we haven't spent enough time talking about it or studying it or investing in it. And so for me, it is both a kind of moral imperative. It is intellectually interesting because by definition, it's going to be kind of innovative because of the dearth of kind of history to this point. It also admittedly feels politically urgent to me. And it feels like there should be the ability to be part of building like really big, sustainable, scalable, kind of glass shattering and market meaningful companies.
And it's a place where representation matters too. And I think kind of thinking about the lived experience and looking around this room and having had conversations with many of you over the course of the morning, we're each coming to this work, to this drive for innovation from our own lived experience. And so our lived experience, although yes, we are individuals, it matters, but also that of our moms and our cousins and our friends, that being able to incorporate that also matters. And so I think it's a space where, as you talk about kind of women's health and your investment in women, that given women or underrepresented minorities a seat at the table means that we are by definition going to be talking about different sorts of problems and also different sorts of systemic solutions than would otherwise be elevated.
Well, we were talking, Megan, as we walked over here about the kind of total absence, bluntly, of Native and Indigenous Americans in most conversations in the public health arena, in the medical arena, in kind of the health equity arena, in the health investment arena, despite the fact that we know that kind of on a per capita basis, COVID hit Native Americans the hardest. Our maternal mortality is the worst among kind of Native and Indigenous women. The Indian Health Service has all sorts of incredible nobility, but also weird funding quirks around it because it doesn't it's not an entitlement program. It's effectively block grant funded. And so sometimes it is constrained in the services that it can provide to kind of Native and Indigenous populations that it is, constituted to provide for. And so I hope too, Megan, that kind of those of us who are in kind of rooms and spaces or on stages like this who care about women's health, who care about kind of the health of underrepresented populations, who care about kind of health equity, who care about kind of democratizing in a scalable and sustainable way access to innovation, also can ensure that we're thinking about everyone in our country.
Well, and as you and I were discussing, for those who aren't aware, the data around Native American health is largely segregated out of kind of the larger health databases for such as they are across the country. So there's the lack of investment, there's a lack of even awareness, and there's a lack of sharing of data that could potentially lead to great innovations, social entrepreneurship, for-profit companies, which leads to an interesting question, which is, again, as I look back at kind of your trajectory of work over the course of your career, you've both been committed to science, but also, again, going back to that scalability question, are committed to creating a pathway for others to take things and make it profitable. And I think one of the challenges in public health is that we often rely largely on philanthropy in order to fund it. We say it's a public good, therefore, someone's going to, we're going to put this good out there in the world, and then it's going to get funded. All of you in the audience know that's not, unfortunately, often the way that it works. You've talked a little bit about how you created those partnerships for the manufacturing of generic drugs, but would love to hear about how you think about how to decide when something comes to you. Is this something that is venture ready? Is it something that should push for policy change? Or is it something that really needs to go down the philanthropic route? And if so, how you advise them on sustainability? The last thing I'll say there in asking that question is, I think that mandate of sustainability as we launch new things into the world matters so much for health, because we have an obligation to the communities in which we're working. I think one of the worst things that we can do is to come up with a brilliant idea, have funding for 2 or 3 years, and then to disappear from a community that's already marginalized and is already distrustful. I think that worsens health and partnership in immeasurable ways. And I think that you have created some really nice models of how to not disappear.
Well, thank you. And I certainly agree. I mean, we were talking earlier about kind of the obligation to treat and to continue to treat, and kind of what that kind of should and needs to look like. I was reflecting them again when you were asking the question about some of the conversations I've been having recently about trying to broaden access to the GLP-1 inhibitors. And the number of people who have come to me with my kind of philanthropy hat on and saying, like, great, like, I want to fund this for a year. Like, all right, so then who's going to fund it for the second year? And like, well, hopefully, like, it'll just be proven to work in fill in the blank community in which they're compelled to engage. And I'm like, I would love to live in a world where data is sufficient.
Mm-hmm. Amen.
Like, I want to live in that world so badly, and yet we don't. And so I think a lot about this, and maybe presumptuously you'll invite me back next year and I'll have a better heuristic, because right now it is really just through individual conversations and trying to help, often particularly college or graduate students, think about how best to achieve kind of their ambition. They've often thought a lot about why, like, why am I the person to do this, or like what they want to do. But they haven't often thought about like how they really want to do that, and should this be really them like going to advocate at the federal or the state or the local level? Because I also often meet young people who think like all policy is set at a federal level.
Thank goodness no.
Thank goodness no.
Federalism is a beautiful thing in many ways,
and also helping people think through, is this something that could and actually should be kind of venture backed? Actually, is this really more of like a community-based organization model? Is this something that I actually already know some entity is doing, and maybe they should see if they can get a job at that entity? And so it is more kind of individual, because each kind of query and questioner is so idiosyncratic. But I will like put a stake in the ground, and if you invite me back next year, I'll have kind of more of a cleaner paradigm.
It's a date. So I'm going to ask one final question, and then I'm going to open it up to the audience. We're both professors as well as innovators and practitioners. You teach regularly in a school of public health. I know many of the folks in the room are students, and those that aren't are here partly because it's fun to be a student for a day. And so I wondered your thoughts about kind of advice for those in the audience who are trying to figure out how to both create a career path and create social impact. If you were someone who was starting out again, what advice would you give? Maybe put on your mom hat.
So I I first thought about getting a PhD actually when I was still at Stanford. And I did my first kind of post-grad degree at Oxford, where I studied international relations because I was obsessed with kind of why the world had felt the need to create the Global Fund to fight AIDS, tuberculosis, and malaria when there already kind of was a program that had been rather, at the time, substantially funded at the World Bank. And because I just had enormous kind of admiration and sort of an academic crush on a woman named Dr. Nairi Woods, who became ultimately my advisor and is now the dean of the Blavatnik School of Government. And so I went there thinking like this is going to be the entree into getting my doctorate degree. And then one day, and I remember this so vividly, I was in the process of like applying to PhD programs. I thought hoped I'd be able to stay at Oxford, but I also had applied kind of elsewhere back on this side of the Atlantic. And I remember so vividly being like, oh my gosh, I'm 23. And if I go and get my PhD, I'm going to be like 28. And I'm going to know a lot about one thing. And that didn't feel inspiring to me at the time. That felt intimidating. And so I thought, okay, it's not the right time. I worked at McKinsey. I learned a tremendous amount. I worked in financial services and technology and in the healthcare practices. I then went and I worked on Wall Street for another kind of few years, also learned a tremendous amount, worked in healthcare, financial services and renewable energy. And then was like, you know what? I think I'm ready to go back and get my PhD. I think now at like 28 or 29, I'm ready to kind of make that commitment. I know this question has been rattling around in my brain. I know that's what I want to do. I had really enjoyed kind of the teaching experience I'd had while working on my PhD. I realized with enormous respect to those of you who are all full-time academics, I didn't want to be a full-time academic, but I've always loved teaching and I've always loved research and I've always loved the kind of permission that being part of large-scale research efforts that kind of teaching and my doctorate degree have given me. I learned so much from students, whether in kind of informal conversations or when I'm in front of a classroom. I find it scarier to teach than anything else I do. I find it scarier than like sitting on this stage. I find it scarier than giving a live interview. I find it scarier than speaking in front of like thousands of people because I'm trying to help someone think critically about something. I'm not trying to just give them a piece of information. I'm not trying to convince them to do something. I'm trying to help them hopefully ask better questions. And that to me is a different charge and dynamic. And so it always feels scarier to me because if my students don't do as well as I had hoped they would on whatever assessment, if they all don't do as well as I'd hoped they would, like that's on me. Like I didn't help them think how to ask kind of better questions. And so I have always kind of loved having teaching part of my life. Sometimes it was the main thing I did. I would teach, 2-3 classes a year. Now I'm just very grateful that my friends invite me to kind of give a few lectures a year. And it still is what I find like the most heart palpitating. And I do think it's important, as sort of all the Hallmark cards say, to still do things that scare us. Because we learn something kind of in the reckoning and hopefully the persistence through kind of those nerves.
Hear, hear. I think back to when you and I chatted about a year ago before I started this job and the nervous palpitations about stepping into something new. And one finds amazing ways to grow and in taking those steps into things that scare you. And I hope that all of those in the audience are able to take those steps into things that make your heart beat a little faster also. With that, I'm going to open it up for questions from the audience. I think Michelle is going around.
Was it Michelle? Is that why you wore your yellow jacket?
I shouldn't have shared your name.
Like your
you guys are
jacket.
good.
Hello. Yeah, thanks. It's a great talk. I appreciate Megan and also Chelsea's input. So I was actually curious about your views on addressing generational health disparities. What innovative strategies do you think can be implemented to ensure that health improvements are sustained across generations, particularly in underserved communities?
Cool. And what's your name?
Julia Rosander. I'm a Blavatnik Fellow with Yale Ventures.
Great.
Yay. Yeah.
Well, Julia, I think, in many ways, kind of what we reflected on earlier or what I shared about the market shaping work, hopefully then, and at least this thus far has been our experience, kind of persists. And you hope too, even thinking about the playground example, while we worked with one playground manufacturer, and there are now 1,200 some odd playgrounds that exist, across the United States, other playground manufacturers have started to also make their own versions of kind of smart playgrounds that have prompts to kind of talk and engage and question and hopefully listen to their children. And so I do think kind of continuing to prioritize investing in early childhood, which we do not do in this country, despite a lot of rhetoric to the contrary, through ways in which we can, as kind of community partners or philanthropic partners, is important. But we also still need to continue to invest in efforts to ensure that the federal government, as well as state and local governments, particularly the federal government, invests again in what we know works. I mean, one of the most painful moments last year for me was when we let the expanded child credit just lapse. Why was that painful? Because we knew that it had more than doubled the number of children who'd been lifted out of poverty. And we know that without kind of continued structural support like that, those children fall back into poverty. And we know that children who grew up in poverty are not only much more likely to have myriad kind of health consequences of growing up in poverty, but they're also much less likely to escape poverty. And so I think, we in our world with the levers that we have, we'll continue to do what we can kind of across the global South with partners and here in the United States with other partners. But as a citizen, as a voter, I know that what really makes a difference on breaking intergenerational poverty is actually transforming how we think of family values in this country and actually valuing the most vulnerable, especially our kids, and supporting them over their lifetime so that poverty is not kind of the sentence that it is today, but hopefully a very small part of someone's lived experience and story.
Thank you. I think I saw the mic get passed up front here, so yes.
Hello, Margaret Cartier. I'm with the Yale Center for Biomedical Innovation Technology. I'm interested in learning a little bit more about implementation success. I work with a lot of faculty and students, a lot of innovators across campus who are really excited about their innovations. As you reflect on all the work that you've done and shared with us, beyond stakeholders and having the right stakeholders at the table, what else are important elements in having successful implementation of new technologies and opportunities?
So I'll talk about that kind of from a global perspective, and that one of the things I most admire, and I admire many things about my parents, is that my father has always had this ethos that permeates kind of every part of the foundation and of Chai today, which is that we should always be trying to work ourselves out of a job. Not because the job stops, but someone else is not doing it. And so if I think about the work that we were really part of, particularly on everything from kind of malaria mapping to kind of distribution of insecticide treated bed nets to kind of more kind of rapid kind of point of care diagnostic work that we had truly Clinton Foundation employees doing a dozen years ago, outside of the malaria mapping, where we still have data scientists who work with our kind of government or intergovernmental partners, we're not doing any of that any longer because either governments themselves are doing it at the kind of national government level or the kind of regional, state, local level, or community healthcare workers are doing it, or local NGO partners are doing it, and we've been able to secure funding for them to continue to do it. And so for us, kind of success, of course, is denominated in how many lives we're able to save for positively impact, hopefully for a lower kind of unit cost, maximize kind of then growing impact over time, but also did we work ourselves out of a job? And so for us, that is part of how we think of implementation.
Thank you. Over here.
Hi, my name's Anastasia Rose, and I work at the Yale Child Study Center downtown. And I'm going to be a future child clinical psychologist. I'm going on to clinical psych PhD at Case Western. So I just wanted to ask a question. You had mentioned ethos earlier and how that's really important for the people that you work with and decide to work with. And I just wanted to ask, what kind of practices do you follow, maybe on a daily or weekly basis, to stay in alignment with those ethos so that you can really do the good that you're hoping to see in the world, and also maybe like how you see that in people that you pick to work with. Because I think there's a lot of different people that we've heard from today, and venture capitalists, different innovators, and I think that just with all the different opportunities coming at you, I can see it being difficult to stay in line with your ethos. So just wondering any sort of daily practices.
Those are really, I think, good questions. I will say my mom did some work with the Yale Child Study Center when she was here many years ago, and I have been lucky to visit you down the road. And good luck in your PhD. I hope you're not as lonely as I was. I think you asked a couple of questions. You asked kind of, I think, one about me, about how I stay kind of centered and hopefully healthy enough and self-aware enough to then, to your second question, be able to think through, excuse me, and recognize like who I would want to work with. On the first, I spend like any free time I have with my children or running, basically. I wish I could see more of my friends. I have a lot of late night phone calls with my friends, but I work a lot, and I have 3 children under the age of 10. And my parents didn't really miss anything when I was growing up. I mean, my father still feels badly about like the 2 softball games and like the 1 choir concert he missed. Still to this day, I'm fine. But I think I'm partly fine because he felt so badly about that he missed very few. So I'm unapologetically aware about like what my priorities are. My priorities are my children and their health and their well-being, and trying to do whatever I can with the resources and the platform and the ecosystem and the friends and the mentors and kind of what I know and what I hope to know to try to build the world that I want them to grow up in. So when I think about like who do I want to work with, I like working with people who have a blend of confidence and humility. Confidence about what they know, confidence in their purpose or their passion, and also humility about what they don't know. They may know a lot about the science, but they don't know a lot about implementation. Or they may know a lot about how to kind of navigate a local health system, but they don't know a lot about the science or how to think about kind of what the right metrics of success should be over time. I like working with people who like working with people. I mean, I have a lot of friends who I'm so thankful like live in labs. And labs are also often like team efforts, I know, but like who have this like, I want to like burrow deep into a problem, and maybe it's going to take me like 5 years to figure this out. But the satisfaction I'm going to have of like the salience of what I will have discovered, and hopefully the applicability of it, is going to be like my metric of success. I like working with people who like working with people, who want to learn from each other, who want to collaborate, who want to problem solve, who recognize that, as trite as it may sound, like the whole is greater than the sum of the parts. I like working with people who find joy in the work, even when it's really hard. I like people who believe in the importance of persistence. I like people who don't run toward conflict but aren't afraid of it. I like people who both respect and are expected in turn to be respectful. I like to work with people who understand why I say to my children, I hope a lot of things for you. But as your mom, what I hope I'm able to give you are the resources and the understanding of the importance of being kind and being brave. So that's a little bit of kind of what I look for. And I am a big runner. I run very early in the morning, often. it's a fascinating time to like watch a place wake up. Particularly, I'm lucky enough to live in New York. I've lived in New York longer than anywhere else. It's definitely my home. Like if you go for a run at like 5 or 5:30 in the morning, right? You see the people coming home from the bars. You see the people going to work. Excuse me. You often see like changes in like the fire department or the police department. You see the sanitation workers who are doing their heroic work. And that's an important part of my mental health too. I know we're almost out of time, but can I just exploit the fact that I'm holding the microphone?
Go for it, Chelsea.
Okay. I don't know what was talked about this morning because I was lucky enough to come and like see some friends and meet new people and spend some time with KP and spend some time with Megan. But it is 2024 and it is an election year. And I don't know if anyone else has talked about the importance of voting or ensuring that your friends and family are registered to vote, kind of know when and where they can vote. But everything that we've talked about, everything that was probably already talked about, everything that will be talked about will be impacted by the elections in November. All the things we hope for the NIH, what if we don't have an NIH? All the things we hope for the National Science Foundation, what if we don't have one? All the things we hope for value-based care, what if CMS gets stripped? All the things that I hope for expanded Medicaid, what if it doesn't happen? All the things I hope for environmental regulations, what if we no longer have an entity of the government whose job it is to actually continually assess and make recommendations about what environmental health looks like? And I will say too, because we talked about women, if you care about women, I know we're in a state where our reproductive rights are protected, but there are 14 states in this country and more than 30 million American women of reproductive age who do not have that fundamental human right.
Hear, hear.
That matters too, because, Donald Trump has said he'll leave it up to the states. That's not good enough for me. He also has been a little wishy-washy, actually, around whether he would leave it up to the states or push for a national abortion ban. He certainly seems to be quite familiar with the Comstock Act.
Which, for those who aren't familiar, is the kind of old-fashioned 1800s act that banned birth control, among other things. So that's concerning. He seems soft on a lot of other details, but not as it relates to what could actually impact a woman's health and well-being. So I just feel like, yes, as my parents' daughter, but more importantly, as the mother of a daughter and 2 sons, can't sit here and not bring my citizenship, as well as my kind of nonprofitness and my investingness and my professorness and whatever other identities I'm lucky enough to have in me every day. I'm also a citizen, and so I suspect for most of you. Here, thank you. With that, on behalf of the Yale School of Public Health, Yale Ventures, Josh Jabal, thank you so much for making this possible. And the entire Yale innovation community, Chelsea, from the bottom of our hearts, thank you for all you do and all you are. And may we take some of these lessons, messages, and drives towards action with us as we go throughout this day and throughout our lives.
Well, Megan, thank you so much. Josh, thank you. Thank you, everyone.